Welcome back. Today we're going to talk about antidepressants. So basically, when we talk about antidepressants, we are obviously talking about giving drugs to people who are, or patients who are suffering from depression. So it's useful to know a few terminologies. So we have the term major depressive disorder. Okay. Or we can sometimes call it endogenous depression. So when we talk about this depression, it is a mood depression, okay, without any obvious medical or conditional or situational causes. Okay, so we have a mood that is depressed, and there is no obvious, no clear medical or situational causes. Because if there is a medical condition, like for example, if the patient is having a brain tumor, for example, or is having epilepsy, and so we might be able to handle those things first before we try to straight away jump into a conclusion saying that the patient is depressed. Or if there is a situational cause, for example, it's a temporary condition, someone is moving out, or is someone just got divorced or something like that. So it might be something else. Okay, we might give another kind of diagnosis for the person. But in this condition, so there is no clear medical or situational causes, and it's manifested, or it presents with an inability to cope with ordinary events, or to experience pleasure. So patients who are depressed, we don't see a clear medical or situational cause. Okay, meaning there is no clear current stressor that's happening to the patient that clearly precedes the depression that the patient is having, or the depressed mood that the patient is having. And they are unable to cope with the simple or not so simple ordinary events in their lives. For example, going to work, okay, getting married and all that. So they are not able to cope with those events, and they are not able to experience pleasure, okay? So things that were previously pleasurable to the patient or to the person becomes not pleasurable or less pleasurable to that person. Okay, for example, someone maybe might used to love doing sports, or going to the cinema, or watching a movie, or having a sexual relationship with someone. Okay, he no more or she no more derives pleasure from doing all those. So that's also another manifestation of depression. So before we dwell into the topic, we have to always go back to the basic neuroanatomy, basic neurophysiology. and revise basic pharmacology stuff like pharmacokinetics and pharmacodynamics, and also have a quick recap of the cholinergic and also adrenergic systems, whether it's the cholinergic agonist systems or the cholinergic antagonist or the adrenergic agonist or the adrenergic antagonist. So some common learning objectives from studying antidepressants. Okay, so basically when we talk about treatment of depression, so we always try to approach it through the biopsychosocial approach. Okay, biopsychosocial approach. So we tend to first look at the biological issue. Are there anything that can be fixed biologically by correcting the anything that is probably imbalanced or not normal? Any readings in the lab that is not normal? Any readings in the imaging like X-ray, CT scan, etc. that is not normal that can be addressed? So that's biological. Okay, psychological. Okay, so is there anything that can be addressed psychologically? And also we also address the social issues. Okay, so some of them might need to be referred to the welfare department. Okay, so that they can get money. Okay, because they are probably broke, etc. They have so many problems with money. So if you cannot solve, so money is a big issue. So if you cannot solve the money issue, of course you will be it will be difficult for you to overcome your down or low mood. And then homelessness, probably. Okay, if you have home issues, you don't have a house, of course you are going to be depressed, probably. Okay, or your depression is going to perpetuate. It's going to continue for a long time if you're homeless. And there are also many other social issues. Okay, problems with the siblings, family. Okay, spouse, children, okay, grandchildren, all of these can potentially lead to depression. And if you don't remove the problems, so it's unlikely that the depression will improve. So when we talk about the drugs that we use to treat depression, okay, so the biological approach. So the drugs that we used in major depressive disorder, they have a variety of chemical structures. So they have a varied chemical structures, and many have effects that enhance the actions of norepinephrine, okay, serotonin, or both serotonin and norepinephrine. So they enhance the actions of norepinephrine, serotonin, or both these neurotransmitters in the central nervous system. So that's what the antidepressants usually do. So biological approach, so that's our focus for today, antidepressants. So it's usually given for moderate to severe depression. We tend not to give the drugs for mild depression. So it has to be moderate to severe. Mild depression, we can just give counseling and probably a little bit of CBT, cognitive behavioral therapy, or other therapies, other psychotherapies. So maybe we can use those things to tackle the mild depression. But with moderate to severe depression, we tend to start them on antidepressants. And SSRIs, the selective serotonin reuptake inhibitors, this group of drugs tend to be the first line medications for treating depression. So the SSRIs, these are drugs that selectively inhibit the serotonin transporters. okay, and they have only small effects, okay, or modest effects on other neurotransmitters other than the serotonin and the norepinephrine neurotransmitters. So their focus is mainly on the serotonin transporters, okay, and they do not really affect that much the other neurotransmitters other than the serotonin, okay. So that's the first line. Second line can include other drugs, including drugs like mirtazapine, reboxetine. So why do we tend to choose SSRIs? It is because they are safer in overdose, okay, and also better tolerated than the other classes of drugs, especially the older drugs, okay, not so much of the newer drugs. The newer drugs will depend, but for the older drugs, the older drugs, especially the tricyclic antidepressants, okay, monoamine oxidase inhibitors. So tricyclic antidepressants, monoamine oxidase inhibitors. So these are the older drugs. Sometimes you might start patients on lithium, okay, to augment the antidepressant effect, okay. So, and also we can give lithium for long-term prophylaxis or for treatment of patients who are resistant to conventional or usual treatments for depression. And then the other option is electroconvulsive therapy, ECT. This is mainly for severe or resistant depression, okay? Patients who really are not responding to the usual treatment for depression might be started on ECT, electroconvulsive therapy. Okay? In ECT, we usually bring the patient to the operation theater, the OT, and then give them some anesthetics and sedatives so that they fall asleep. Okay, and then we induce a fit in the patients. Okay, it's a mild fit. So we hope after treating them with ECT for a few rounds, okay, on a few sessions, they hopefully will have some improvements in their symptoms. So this is usually done by in the psychiatric department, okay, in the operation theater, by probably the medical officer and secretary, or maybe some places by the psychiatrist or the specialist. And then we have the antipsychotics. Okay, so mainly this is the mainstay of treatment for depression. So this is the focus for today's lecture, and the others you can just probably ignore and just have that in mind as a general knowledge. Okay, because this will be taught later on in your fourth year of medical school. So this is an example of an SSRI, okay, selective serotonin reuptake inhibitor, okay, that blocks the serotonin transporter, okay, the SERT, serotonin transporter found on the presynaptic region. So this is fluvoxamine. Okay, you have to remember the name fluvoxamine. Okay, you don't remember the brand name, but of course, if you can remember the brand name, you might be able to remember the generic name or the standard name, scientific name, fluvoxamine. Okay, so this is one of the common SSRIs that are used on a daily basis in many places. So antidepressants, there are at least 6 categories, okay, according to their mechanism of action. So we have the monoamine oxidase inhibitors, such as phenelzine, selegiline, monoamine oxidase inhibitors, okay. So there are two types, I mean MAOIA and MAOIB. Okay. And then we have the tricyclic antidepressants such as amitriptyline, clomipramine. Next, as the third category, is the heterocyclic antidepressants. Okay, heterocyclic antidepressants. Example is bupropion, mirtazapine. And then we have the what's called the serotonin norepinephrine reuptake inhibitors. Okay, serotonin norepinephrine reuptake inhibitors, the SNRIs. So examples include duloxetine and venlafaxine. Next category is the serotonin antagonist. Okay, serotonin antagonist. So we have nefazodone and also trazodone. Nefazodone and trazodone are examples of the serotonin antagonist. Next is the main category of drugs, which is this is the number one. Okay, the most important category among the antidepressants is the SSRIs. Okay, the SSRIs. Okay, SSRIs, very important. Example, escitalopram, fluoxetine. We have fluvoxamine. Okay, which the picture I've shown in the previous slide. We have paroxetine, sertraline, this one you can add imipramine. Okay, there are so many actually, the TCAs. This one, not so important. Trenyl cypromine. So basically the most important one is this. Number one, I would say the ranking is number one, this. Then this. And then this. And then this one, okay? So in terms of priority for memorization, so this is number one, number two, number three, number four, okay? So try to remember as many SSRIs as possible, and then remember the SNRIs, and then remember the heterocyclic antidepressants, and then the serotonin antagonist. So next, let's talk about the Amine hypothesis of mood. Okay. So this is what we call the this is a hypothesis that is the backbone, okay, or it's the spinal cord of understanding antidepressants, okay, how they work. So this hypothesis, it postulates that the norepinephrine and serotonin, okay. So we postulate that these are the neurotransmitters that are essential, or they are pivotal in mood expression. Okay. So these two brain amines, okay, so they are the neurotransmitters that are the most important in mood expression. So if there is reduction in the activity of norepinephrine and serotonin, we are going to get depression. Okay, that's the hypothesis. And vice versa. So if you see an increase in the activity of the norepinephrine and serotonin, so we believe that the mood will be increased. Okay, so you have increased mood, and if it's increased too much, you get hypomania, and if it's again too much, so you get mania. Okay, you get mania. So the hypothesis is based mainly on studies that show that there are many drugs that are able to alleviate the symptoms of MDD, major depressive disorders. So they tend to enhance the actions of norepinephrine and serotonin, or both, okay, in the central nervous system. Okay, so but however, this hypothesis, of course, is not bulletproof. It's not foolproof. Okay, there are problems with this hypothesis. Okay, firstly, the first problem, the first objection, comes from the fact that when we did postmortems, okay, when postmortem studies were done on patients, they did not find a decrease in the serotonin or norepinephrine levels, okay, in the brain. So that's number one. They didn't find that in the postmortem findings. Number two, we can change, okay, we can change the brain amine activity within hours, okay, with antidepressants. Okay, we can change the level of serotonin and norepinephrine within hours after giving those drugs, those antidepressants. However, we only see changes. We only see response clinically, okay, within only after a few weeks. So then that's not really matching, okay? You already changed the levels of norepinephrine and serotonin in the brain, but then you're not seeing any changes in the symptoms unless after you wait for a few weeks. So that's a second objection. And the third objection is that the third argumentation against this hypothesis is that most antidepressants ultimately cause a reduction or downregulation of the amine receptors. So eventually, when you give these drugs for some time, you're going to see a reduction in the amine receptors, okay, the serotonin and the norepinephrine receptors. But at the same time, you are seeing improvements in the mood of the patients. So this is an argument, okay, a fact that opposes the Amine hypothesis. The fourth thing is that drugs such as bupropion, okay, bupropion, which is also given, and it's effective, comparably effective with other drugs. It's used to treat depression, and this drug, even though it's able to tackle or improve the symptoms of depression, this drug exerts minimal effects on the norepinephrine and the serotonin. So that's the fourth argumentation against this hypothesis. And the last one, okay, the fifth one is that studies have shown that there is a reduction in the BDNF, okay, the brain-derived neurotrophic factor. Okay, there is a reduction in the BDNF levels in the brains of depressed patients. Okay, so how does that match or tally with how is that relevant to going against the hypothesis, the Amine hypothesis of mood? Okay, that's for you to find out. So abbreviations that are commonly used NA, norepinephrine, or noradrenaline, okay, and E, serotonin is 5-HT. So in this slide, we were going to talk about 5-HT and also 5-HT. Sometimes we're going to talk about 5-HT2, okay, serotonin 2, okay. So this is different, okay. It's not the same, even though they are both serotonin. But in this context of lecture, we are going to talk about it in a slightly different manner. So they will be addressed in a slightly different manner. So drug classification and pharmacokinetics. But however, we're not going to talk about the pharmacokinetics because it's going to take too much of our time. So we're just going to talk about the drug classification. So first we have the classical TCAs, heterocyclic antidepressants. Example, imipramine, amitriptyline. And these drugs, this category of drugs, they are structurally quite related to the phenothiazine antipsychotics, and they even share some of their pharmacological effects. Next is the SSRIs, selective serotonin reuptake inhibitors, which fluoxetine is the prototype of this drug, of this group of drugs. So in this category, we have fluoxetine, citalopram, escitalopram, fluvoxamine, paroxetine, sertraline. Okay, so those are the main ones. And then we have the heterocyclics. So this category of drugs, they include the SNRIs, okay, serotonin norepinephrine reuptake inhibitors. Also the venlafaxine and also duloxetine, okay, duloxetine and also levodopa cipran, okay. So that's I've not seen that drug being used previously. Okay, sure whether it's used or not. So, but I've seen duloxetine and venlafaxine. Of course, I've given venlafaxine previously to patients who are depressed many years ago. And then we have this serotonin 2 blockers, mainly nefazodone and trazodone. And there are, of course, other miscellaneous, okay, miscellaneous ones. Like amoxapine, bupropion, methylpropyl, and also mirtazapine. The third category, the fourth category is the monoamine oxidase inhibitors. And so this one is much less important, I would say, compared to the second and third ones. Okay, so these are much more important. Then only after studying this thoroughly, then only you study the TCAs and then the MAOIs. So as mentioned previously, most of the antidepressants, they potentiate the actions of norepinephrine or serotonin or both. Okay, norepinephrine, serotonin, or both. And nefazodone and trazodone, however, they are weak inhibitors of the norepinephrine and serotonin transporters. And their main action is antagonism of the serotonin 2A receptor. So TCAs, the main acute effect of these drugs, of this category of drugs, is to inhibit the reuptake mechanism of both norepinephrine and serotonin in the brain. So we have the TCAs blocking here, okay? Anti is neurotransmitter. So mainly norepinephrine and serotonin. In the case of, when we talk about antidepressants, of course, it's norepinephrine and serotonin. So we block here. We cannot have reuptake, proper reuptake of norepinephrine and serotonin. And that will, of course, lead to increase in the availability of norepinephrine and serotonin here, and they can exert their effects on the receptors, okay, on the norepinephrine and serotonin receptors, and hopefully that will lead to elevation of the mood. So that's TCAs. Second, SSRIs. SSRIs, as previously mentioned, it acts on the serotonin transporter. Okay, this one. SERT, serotonin transporter. So SSRIs act here, causes inhibition. So similar concept to the MAOAs. To the TCAs. You block here, you block the reuptake, so you have an increase in the availability of norepinephrine and serotonin. Mainly the increase in the serotonin, okay? Because it blocks the reuptake of serotonin. So you have increase in serotonin. So this will act on the serotonin receptors. Okay, and hopefully again you will get improvement in your mood, okay, in the mood of the patients. Next category is the SNRIs. So SNRIs, they block both the the SERT, the serotonin transporter, and also they block the transporters for norepinephrine, the norepinephrine transporter NET. So when we compare the SNRIs compared to the TCAs, so the SNRIs have a significantly reduced antagonistic or blocking effects on the peripheral receptors. So they have less effects on the histaminergic, muscarinic, and also alpha adrenergic receptors. So potentially this will cause reduced or less adverse effects or unwanted effects with regards to these receptors. So the next group is serotonin 2 receptor antagonist. So it's mainly because of the action on the serotonin 2A receptor. So the two main ones are nefazodone and trazodone. And this receptor is a G protein coupled receptor. And these receptors are found in multiple regions in the central nervous system. So when we antagonize, we block this receptor, we hope to see anti-anxiety and antidepressant effects. Okay, the fifth category are the other heterocyclic antidepressants. So mirtazapine increases the amine release from nerve endings. Okay, it causes more of the amines to be released from the nerve endings by blocking the presynaptic alpha-2 receptors. Because this receptor is involved in feedback inhibition. So when you block this inhibition, so you can there is reduced in the inhibitory transmission or inhibitory messages that is being transmitted. So that therefore we will have an increase in the release of neurotransmitters. And this drug is also an inhibitor at the serotonin 2 receptor. So mirtazapine. As with bupropion, even though it's also a heterocyclic drug, we are not really clear about the mechanism of action of bupropion. Okay, how does it exert its antidepressant effects? And this drug has no effect on either the serotonin or norepinephrine receptors, and not even on the amine transporters. Okay, so no effects on the NET, norepinephrine transporter, no effect on the SERT, okay, serotonin transporter. So this is what is interesting about the bupropion. So the last category is the monoamine oxidase inhibitors. So these drugs will increase the amine levels by interfering with their metabolism in the nerve endings. And that will cause an increase in the vesicular stores. Okay, we have the vesicle stores of norepinephrine and serotonin. So we will have more of this when we block the monoamine oxidase. Because monoamine oxidase will act upon this and turn it into something else. Okay, you still remember your biochemistry? Okay, it will break down this serotonin and monoamine and your norepinephrine. So when you don't break it down, you block here, you block your monoamine oxidase. So you'll have more available serotonin and norepinephrine, okay, to act on the postsynaptic serotonin and norepinephrine receptors. Okay, in the next video, we will talk about the pharmacologic effects of antidepressants.